For some people living with MS, pain is a reality. The good news is that there are real treatment options available too. Welcome to Ask an MS Expert. I'm John Strum, your moderator and host of the Real Talk MS podcast. Each week, Real Talk MS reaches thousands of people in more than 100 countries around the world with the news that people affected by MS need to know. My wife, Jean, lived with progressive MS for 23 years. So I've had a front row seat experiencing all the ways that MS can impact a family. Today, I'll be asking our expert the questions you want answered. Please feel free to post your comments and questions on Facebook, YouTube, or Twitch. MS Navigators will be online throughout today's live program, answering your questions and connecting you to resources. Pain is a very complex personal experience, and while not fully understood, pain is also a common symptom of MS. The distraction and discomfort of MS pain can get in the way of fully engaging in virtually every aspect of your life. And joining us today to talk about managing MS pain is Dr. Bianca Weinstock-Guttman. Dr. Weinstock-Guttman is a neurologist and professor of neurology at the Jacobs School of Medicine and Biomedical Sciences at the University of Buffalo. Welcome, Dr. Weinstock-Guttman, and thanks for being with us today.
Thank you for inviting me, John. I'll be very happy to be here with you.
I always like to get our definitions out of the way at the very beginning of these conversations. So I'm hoping you'll explain the difference between neuropathic and musculoskeletal pain.
Yes. So in general pain, we do have in MS more specifically, if you want to talk, the neuropathic pain or central pain are related to direct injury from MS process, meaning inflammation and demyelination on what we're calling spinothalamic, meaning the sensory pathways in MS from spinal cord, going on to the hub, the thalamus, and up to the parietal lobe. The musculoskeletal pain are related to the spasticity, tightness, gait abnormalities, and sure enough, posture abnormality, secondary related to the disability of MS. Unfortunately, also falls that may injure the joints. So they are different. Unfortunately, often MS patients have both a complex, also neuropathic, and also neuromuscular pain, musculoskeletal pain. So we have more complex intervention for each of them and maybe combined.
How might someone living with MS experience these types of pain?
So the neuropathic pain are usually perceived as burning sensation, shock-like sensation, well, and mostly on the face, on the back, on the limbs, while the musculoskeletal pain are also experienced sometimes in the limbs, but more as a the tightness, spasticity, deep pain. Now, if we're talking about the neuropathic pain, and they are usually associated with more significant disability. We know mostly of the trigeminal neuralgia. This is the worst pain possible, affecting the face. We do know also of many of our patients know about Lermite phenomena, the tingling electrical sensation going down the spine when someone is flexing in the front head. The third one that is less frequent but is also very painful is the so-called painful tonic spasms. Sometimes we call this spinal seizures, coming on from spinal cord lesions, also usually extended lesion and the cervical lesion or thoracic lesions. So that is what usually we see in the neuropathic pain. On the musculoskeletal pain, again, it's the usual tightness and the spasticity, also in the limbs more, but you can have also in the back. It's mostly often related to joint problem, meaning back pain and abnormal gait, abnormal posture. I have patients that, only changing the walking from a cane to a walker. the pain went away. So that is very important to be aware and provide all the recommendation based on the patient problem.
Now, pain can be described as either acute or chronic. What might make pain either acute or chronic?
So in general, in medicine, we do have this very specific limitation time-wise. Acute, something that is coming up, lasting only 1 month. It's kind of artificial. Chronic, anything that's lasting more than 3 months. Now, same we can do also arrange and explain in MS. The acute pain usually are neuropathic, and as already mentioned before, could be the trigeminal neuralgia or the Lermite phenomena. The chronic pain are possible also related to longer time of maintaining the pain, and usually it's a different reason, pathological, pathophysiological lesion related to chronicity. So an acute lesion and acute pain becoming chronic. And that's because there are very proximal area that are maybe affected from the initial injury that produced the acute lesion. They are extended towards a different areas. The nervous system wants to fix, and the problem that they're fixing, it's not a perfect. And this is what is bringing on actually the chronic pain. We see this in central pain as MS, but also neuropathy and peripheral pain. When, as I said, the nervous system wants to fix, but the fixing, it's not perfect, but extending in the areas that giving, in the end, the reason for the chronic pain.
So, we've heard from Omar, who tells us he experiences occasional pain that doesn't last long, but it's always in the same part of his body and causes the same sensations. How can Omar know if his pain is either acute or chronic?
That's a hard question. And as I said, it's depending on how much it lasts and the frequency in between. As I said, it could be sometimes, short lasting positional pain. That would be a more musculoskeletal. It could be, as I said, bending forward, the Lermite phenomena. That is sometimes when we think about a reason for the neuropathic pain, if the symptoms are very short lasting, not coming up very frequent, maybe we'll not go even to figure out what it is. But when we see the same issues coming up more frequent, lasting longer, we have to figure out what the reason is. So I would say it's hard to say. Sometimes, as I say, I have patients with Lermite phenomena, not as acute, but long time. They are so used they don't even take care. If this becoming much more severe, that's meaning something is going on. I have patients that have women that having Lermite phenomena during periods, middle of the periods. They know everything and they get along. So it's very difficult to absolutely define acute, chronic, but it's more as a length of the time. But the severity, change on it is very important to learn and how to treat.
Are there treatment options available for acute pain?
Sure. So for acute pain, again, we have to go to figure out, is this neuropathic or it is a musculoskeletal? For the neuropathic pain, as already mentioned before, the trigeminal neuralgia, the best are really the what we're calling anti-seizure medication. Before it was called anti-epileptic. Now we have a new anti-seizure medication. And the best that most of the recommendation is to go eventually with gabapentin, pregabalin. But the truth is, the best effectiveness that I saw is oxcarbazepine. When we're taking even a lower dosage, going slowly to control the disease, follow blood tests with sodium not to be going down. So that's are the most effective medication for acute pain. For the musculoskeletal pain, acute one, you have to figure out it didn't, affect the back, any sciatica, anything, so, or any joint pain. So it's a different consideration. We started with an NSAID, but further on, you can go and having other intervention and more physical therapy or muscle relaxant if this is the spasticity related. baclofen, that is a muscle relaxant, is actually having also benefit on pain. So could be helpful. For
And
more chronic pain and so on, sure enough, that's what we know more. It's maintaining the medication that we give into acute pain, but also non-pharmacological intervention. And it's important to people to know about, to believe on it. Because really what I'm talking to my patients, if you're thinking and starting something, if you from the beginning say, this will not help, that was seen actually in the research things. If the patient's going on in the research and they're thinking that the pain, whatever we try will not help, will not help. So the mind is doing a lot. So the mind can be helpful on treating. So we have a mindfulness, we have a CBT, the cognitive behavior therapies, relaxation. We do have methods to learn biofeedback, how to control our pain.
I want to circle back to some of those in just a moment or two. Well, we heard from Bethany, who says she was diagnosed with MS 5 years ago. And, like a lot of people living with MS, she's experienced spasticity. Can you explain what spasticity is and how it could be contributing or even causing Bethany's pain?
Yeah. So spasticity is really an increased muscle tone. It's a neuromuscular overactivity. It's related to injury to the motor pathways. And sure enough, tightness and so on can give pain. If it takes longer time, it can affect really much more even the joints, provided inflammation. But even more, going back what I said before, it can go from the motor pathways to affect the sensory next to it. And that may increase and consider actually adding on neuropathic pain to the neuromuscular or musculoskeletal pain. So that is the concern, is figured out it's only spasticity, if it's already add on a complex pain related to the extension to the sensory pathways.
And could you talk a bit about the treatment options that are available to help reduce spasticity or better manage it at least?
Yeah, for spasticity, sure enough, we have the usual oral baclofen that, as I said, has also benefit not only in muscle relaxant but also in pain. We can have tizanidine. Initially, they said you cannot combine, but you can combine. Don't take it all together. Tizanidine is much more sedative. It could be helpful more before going to sleep to help you also to sleep. Physical therapy is very important. And sure enough, has to have a good physical therapist, not to push from the beginning to increase the pain, and the patient won't go after then. So slowly increasing this. And after then, we do have different other intervention for pain and spasticity that are not responsive to the initial treatment. And that's as related to cannabis. I know that people with MS tried and so on. Cannabis helps spasticity. As related cannabis to general pain, 50-50, not real. But if the pain is coming from spasticity, cannabis can be helpful. If the pain is very severe, we do have much more different intervention, and that could be, for example, the intrathecal baclofen pump. That can have baclofen much lower dosages, but it's going directly into spinal fluid and having clear benefit on pain. We can add on, not only for spasticity, but for pain, sometimes for pain, it's bupivacaine or morphine. And again, very small dosages. We can, with electronical, computer, divide more in the evening, more in the morning. So we can work on it. But it is an intervention. It is, provided an insertion of this baclofen pump. Other intervention, for example, for the trigeminal neuralgia, also neurosurgical intervention, if the pain is continuing and the oral medication doesn't help. Botulinum injection could be too, even for trigeminal neuralgia, seems more recently helpful. Again, interventional for severe long-term chronic pain. There are other possibilities. I'm not for opioids. And opioids are think it's only chronic and increasing the risk for addiction. So I'm not for it. We do have often also a pain specialist involved, but usually I'm not very much to use it.
I think you've already started to answer my next question, but I'm wondering whether there are common areas in the body where someone living with MS might experience pain.
So as I said before, there are pain from on the face, a pain on the limbs, in the back. I have, for example, clearly more recent studies showing that thoracic lesions can give this burning sensation in the thoracic upper back area. So that is where usually we do feel pain. So or be in different combined areas.
In MS, pain and itching go hand in hand, but it's not physical itching in the traditional sense. Can you explain how itching might feel to someone who lives with MS?
Yeah, that is a very interesting question and actually statement. Itching, when it's coming related to MS, we're calling this neuroitching. And the itching pathways is actually same pathways as the pain. However, the reason for and the treatment for it's completely different. They found even different cytokines or inflammatory markers that are for itching versus for pain. Interestingly, what's the best, and I really had a recent patient that have severe pain coming as events, coming so bad, he was scratching and affecting his skin. And the only benefit I had is using the anti-seizure medication, oxcarbazepine. Sometimes nortriptyline can be helpful too. This was helpful on the itching from diabetic polyneuropathies. The very important thing that I found actually is that the opioids actually are worsen the itching pain, the itching, narrow itching, versus opioid may help some in pain. So it's a completely different, clearly not using opioids. There are also creams. Some, they are very expensive. There are pharmacies that are doing compounds that may have gabapentin, amitriptyline in, sometimes ketamine. There can be helpful too, capsaicin. But again, that has to go to a compound pharmacy and is expensive, but it is helpful.
Liam is wondering if there are other MS related sensory changes that might cause pain.
So as mentioned before, that pain is coming up as neuropathic pain related to the injury in the sensory pathways. But with the time going, when extending abnormally to different other areas, we can see that even the upper parietal area can be affected. And we can see this very increased sensitivity. We call this allodynia, pain without even touching, or hyperalgesia. Patients cannot put on their blanket because the pain. So there are this more severe pain associated with what we're saying, that is chronicity, extension of the lesion. And it all depends on different patients, on their threshold of pain. I don't know if we have time to say, but it was a recent study in healthy individual that they were open to have injection on their muscle here on the master that provoked pain. And they were able to, and after then they asked them what the pain severity is, and they monitored with an EEG with the brain waves and another transmagnetic stimulation, and found that really these healthy people, the threshold for pain is very different, and they found differences on the waves from the brain. So every person is different. The injury could be different, but the sensitivity and response to pain can differ. Someone has a lower threshold and someone has a higher threshold. So that is also individual different.
Sabrina tells us she experiences chronic neuropathic pain from MS. For her, it feels she's
Mm.
wondering whether there is an alternative management strategy. She says she has a solid treatment plan, but is wondering if there are other alternative options that she can incorporate in addition to her medication.
Absolutely. So, as already mentioned before, any kind of intervention that we can use our mind to help ourselves are very helpful. So, the cognitive behavior therapy, mindfulness, but it can be also acupuncture. I do believe acupuncture is good for pain. I'm not sure if it's helpful for weight loss and so on, but for pain can be helpful. Exercise program again very well with the physical therapist that to know how to do it. There are also trigger points that can be helpful, as I said, sometimes more different besides the intervention with pharmacological therapies. There are also neuromodulation. If you probably know about this helmets for headaches, it could be this direct electrical transmagnetic stimulation with a different type of helmets for pain in MS could be helpful too. It's not everywhere available, but yes, it could be also other intervention non-pharmacological.
We heard from Lenny. He says he's noticed a lot of neuropathic pain management is also mental health management. Treatments might include antidepressants and cognitive behavioral therapy. Can you explain the connection between pain and mental health?
So we do have patients with depression before developing pain from MS. We do have depression developing after because the chronicity of the pain. But interestingly enough, we do know that that medication for depression known before can be helpful for pain, but in much lower dosages. The most recent was the duloxetine, right? The Cymbalta that was primarily trial for depression, and they found it have the benefit on pain. So the connection between pain and depression is still not clearly, well known, but it's clearly seen that the medication that benefit depression, all this biochemical imbalance, in a lower dosage can benefit pain. We're using, as I said, the duloxetine, the amitriptyline, nortriptyline. Amitriptyline and nortriptyline in a very low dosage, 25, 50 milligram, can be helpful. To be an antidepressant, we need 100, 200. No one goes there for pain. So there are clearly same pathways used, unfortunately, for pain, meaning secondary to providing pain. And depression is something that we still do not know. We know that it's a chemical imbalance, and we know that medication can help. What I can say is that not all antidepressant therapies are beneficial for pain. And mostly, as I said, the duloxetine, nortriptyline, the tricyclic, or the Effexor, the venlafaxine. The SSRIs are not good for pain.
Interesting.
So if you do have both, and you have to consider going down because we don't want polypharmacy to have in both direction benefit, go on the medication, as I said, on duloxetine or venlafaxine. Lamictal, I don't put it on too much because I have too much side effects. I'm not for it. But it's, as I said, medication that have both also the not only serotonin reuptakes, but also the noradrenaline uptakes, beneficial for pain and not the SSRIs.
So, to avoid or at least minimize polypharmacy,
Absolutely.
how are some ways that someone can adequately support their mental health issues when they're also experiencing chronic pain?
It's a lot of work. Actually, I saw yesterday a patient that was in a lot of medication by herself said, I want to go down to feel better. And requires a lot of people to go and help. Doing, as I said, the evaluation of the mindfulness or learning how to do the CBT, biofeedback. That is very, very important, and slowly going down on the medication. Don't stop at once, but slowly going down on one, especially the one that you feel that is giving you much more side effects. Don't stop fast, especially for trigeminal neuralgia and so on, don't. But slowly try and with your physician, neurologist or pain specialist, very slowly going down, and don't go every 3 months only to get again the prescription refilled. So the patient have to be open to do it. And there is this possibility and the strength there. And as I said, I only yesterday had a patient, a wonderful outcome with slowly being willing and was much better, walking better, talking to me much more. So it's very helpful.
While we're talking about medications, Roberta's wondering whether there's any risk of addiction to MS pain management medications.
Sure, there is a risk for addiction, especially with the opioids. There's same also for cannabis. And we have to be aware about it. Seems that the people with depression have a higher risk, and young patients, higher risk for addiction. Family history for addiction is also possible. It's a genetic risk. So it's important to consider not to start actually opioids and not cannabis. And so it's a concerning issue, and we have to be aware and try different other methods.
Well, you shared some very helpful insights and some excellent strategies for managing MS related pain today. What would you say is the top takeaway that you'd like our viewers to remember and use?
I think that the most important is that we do, as actually practitioners, know that MS is associated with pain, that we can control this. It's a complex procedure. Everyone has to be individualized on which type of pain, and to give a program how to take care of it. And sure, may have pain specialist involved in, but the patient has to be part of it and to be the active participant in controlling the pain along with the physician, and not only asking for another medication.
Well, I've observed that anytime, I'll say every time, a patient becomes a partner in their treatment plan, we see a better outcome, don't you?
Absolutely, absolutely. That is the way to go. Yes. And I will add on that the lifestyle is very, very important, meaning losing weight, not smoking, smoking increasing pain, not alcohol, good sleep, adding on different supplements too, vitamin D, eh, deficiency in vitamins, B12. Actually, also important, B6 too much can give pain, intoxication. So any people that taking too much B, look not to have too much B6 because can give pain. So it's very important to know. After probably, I don't know if it's known about the alpha lipoic acid as another supplement that is today used even as considering in a study for preventing progression in MS. Alpha lipoic acid is one of the supplement for diabetic neuropathy. It may have also central benefit on pain. So I'm starting to use this alpha lipoic acid, especially that may have benefit on protecting progression MS in trying in our patients.
Well, thank you for sharing those bonus tips. And thanks so much for being with us today, Dr. Weinstock-Guttman.
Nice being here.
Today's program survey has now been posted in the chat for your feedback. Please take a minute and complete that survey. It really helps us create the programs and feature the topics with you in mind. Please be sure to visit the Society's website for information and resources on MS, for connection opportunities, and for ways for you to get involved. You can also connect with an MS navigator to receive personalized support by phone, email, or through the Society's website by chat. A recording of today's program will be posted on the MS Society's website at nationalmssociety.org/MSexpert, as well as on Facebook and YouTube. Finally, I'll invite you to join me each week on the Real Talk MS podcast, where we continue the conversation that we start here. You can find Real Talk MS on Apple Podcasts, Spotify, Amazon Music, or wherever you find your favorite podcasts. Thanks for joining me for Ask an MS Expert. We'll see you next week.